That is
Hello, viewers. Welcome back. Good evening, and I welcome you all on the behalf of Indian Medical College to this online class. So, dear viewers, in today's session, we have our enthusiastic and energetic speaker, our beloved Dr. Deepa Babin, who is Associate Professor from the Department of Microbiology from SR Medical College and Research Center, Trivandrum, with us. Madam is having 17 years of teaching and research experience in microbiology, and she has completed her postgrad and PhD in medical microbiology. She'll be taking a class today on the topic meningitis. Good evening, and I welcome you, ma'am. And it's our immense pleasure to have you here with us, ma'am.
Thank you. Thank you, Dr. Kavya.
Thank you,
Thank
ma'am.
you. Thank you.
So, dear viewers, if you have any doubts or clarification, you can just type them in the comment section below, and your queries will be clarified by our doctor at the end of the session. Ma'am, I hand over the session to you. You can just start the presentation. Thank you so much.
Thank you. Thank you. Okay, Kavya. Okay, students, today our session is about bacterial meningitis. So you must be heard about meningitis, a common clinical condition. Usually we'll come across in our clinical scenario. So today in this session, I'm going to deal about only bacterial cause of meningitis. So you all know meningitis is a very vast condition. It can be caused by infectious and non-infectious conditions, including that means infectious means bacterial, viral, parasitic, or even fungal causes can be there. But today we are only dealing with the bacterial meningitis because it is a very vast topic. So I will be later classes, we will be dealing with the other causes. So we'll start first with a clinical condition. So you must be, can read this, that is a 3-year-old child brought to the emergency department by her parents because of high fever, neck rigidity, and loss of appetite for the past 24 hours and difficulty in arousing her for the past 2 hours. And she's showing a positive Brut-Singh's sign. The developmental history has been normal since birth. Her childhood immunization were current, and she attended a daycare center and had a history of several episodes of presumed viral infection similar to those of other children at the center. So this is actually the scenario how a patient or a patient with meningitis is presented. So once again I'll repeat, that is a age of the patient, that is a 3-year-old girl child, an emergency, it is an emergency, medical emergency, come to the medical emergency room, and she's, what is the symptoms? High fever, neck rigidity, loss of appetite for past 24 hours, difficulty in arousing her because she's stupering, and having positive Brut-Singh's sign. And when they have asked the parents about the history, her developmental history was normal since birth, and her immunization was also current. And what actually, one another clue is she attended a daycare center, the 3-year-old child, and had a history of several episodes of presumed viral infection similar to those of other children at the center. So this is how the case presented. So the probable question you can get from this type of condition: what will be the probable diagnosis of this condition? The probable diagnosis can be meningitis. So from where you will get the clue of how will you get the probable diagnosis? Because the first one is the age of the patient, high fever, having neck rigidity, and the patient is stupering, and positive Brut-Singh's sign also. Okay, next question. What are the etiological agents? So in this session, we are going to deal only about the bacteriological etiological agents. That's why I put only bacterial etiological agents. What is its pathogenicity and clinical features? What is lab diagnosis, treatment, and prophylaxis? So these are the probable question you can come across in your exams. So it can be asked as a clinical essay. Otherwise, you can get a short note of enumerate the etiological agent of meningitis. What is the lab diagnosis of meningitis? Okay, so we will see one by one. So what is meningitis? Meningitis is an inflammatory condition of the leptomeninges, the tissue surrounding the brain and spinal cord, and is defined by an abnormal number of WBCs in the CSF. So that is the definition of meningitis. So, little bit anatomy. The meninges consists of three parts: the pyometer, arachnoid, and duramatous. So, bacterial meningitis reflects infection of the arachnoid matter and the CSF in both the subarachnoid space and the cerebral ventricles. So, now you know what is meningitis. What is the definition of meningitis? Okay, now we'll see what are the types of meningitis that I already said. There are different types of meningitis. The main classification we can broadly make them into three: infectious, neoplastic, or even non-infectious. So what is infectious? That is actually related to microbiology. Infectious, again, we can classify it into bacterial, viral meningitis, even chronic bacterial meningitis, mainly TB, tuberculous meningitis, cryptococcal meningitis, that is a fungal meningitis, neoplastic. Next, syphilitic meningitis. You must be heard about syphilis, that is Treponema pallidum, that is an STD condition caused by another bacteria that can cause syphilitic meningitis. So there are the different types, even bacterial meningitis, even viral meningitis, fungal meningitis, even parasitic meningitis also are there. So these are the types of infectious meningitis. In another division is non-infectious conditions also. That is sometimes certain drugs, NSAIDs, trimethoprim, sulfamethoxazole, intravenous immunoglobulin use. They can also cause induce meningitis. Even some vasculitis that is usually related to some autoimmune diseases like Sjogren's disease or lupus can lead to a meningitis condition. Sarcoidosis, even malignancy or metastasis to the meninges can also cause meningitis. So now in our session, we will deal only about the bacterial meningitis, that also excluding TB and syphilitic. That will be dealing next sessions. Okay. So coming to the mode of transmission of meningitis. So what will be the bacterial mode of transmission? Most probably direct contact, indirect contact, mainly through the respiratory droplets, that is the droplet infections. Okay, so direct contact means close contact with patients. Indirect contact means that one can be, that is those uh, things which is handled by the patients get contaminated. So here in our case, that child is going to a daycare center. So in that, already they are telling viral episodes like viral fever, they put it with other students also, other children also in the daycare center. So they can be having a direct or indirect contact is mode of transmission to this child also. And coming to the incubation period, that means when it will start appear after entering into our body. Normally 5 to 10 days after breaking our blood-brain barrier, but lethal in 24 hours or even shorter in young patient. Here also, our child is a 3-year-old child, so it is a very medical, very urgency or emergency in this condition. And the next group of people or those who are transmitting this condition is carriers. You must be heard about carriers, different types of carriers. That is those who are harboring the bacteria or in them, but without any problem in them, but they can transmit the infection to others. So carriers also one mode of transmission in meningitis. Okay, what is the infectious material? Nasopharyngeal secretion. That's why I told you the droplet secretions. Then who are at risk? So it's a wide range. Neonates, children, or even teens and young adults, elderly people, people with weakened immune system, AIDS patient, or with most probably they are more prone to the TB meningitis, that is chronic condition in AIDS patients can be happen. Coming to the etiology. Etiology means what are the bacterial cause. That is our second question. You remember that what are the probable etiological agents. So the etiology can see neonates depending upon the, that is depends upon the age group. We can classify neonates, infants, children and adult. Neonates, group B streptococci, Escherichia coli, and Listeria monocytogenes. These are the main or commonest pathogen. Others also can be infected, but the common one which I put in this category. Coming to the infants, Neisseria meningitidis, Haemophilus influenza, and Streptococcus pneumoniae. Next comes children, Neisseria meningitidis and pneumoniae. Adults, pneumoniae, meningitis, and even mycobacterium also. Okay, so in this slide, you can see I put in highlighted with red letters. So these are the main important one, bacterial causes of meningitis, or the most predominant or pathogenic ones. Others also, that is the main ones, which are they? Neisseria, Haemophilus influenza, Streptococcus pneumoniae, Group B streptococci, and Listeria. So you should, I think you can get a short notes of each one also. Not like meningitis, because they can be asked, what is Haemophilus influenza? Like a 2-mark question. Even Neisseria meningitis can get a 2-mark question. Listeria also we can get. Pneumonia also you can get. So very important, because you will must be in bacteriology class. You will be dealing each bacteria in a separate chapter. So you should, you know at least that is in that session you must be thoroughly studying about its pathogenicity, morphology, lab diagnosis and everything. But here we are putting together all these things and we'll deal one by one. Okay, coming to the pathogenesis. So how this bacteria is affecting us. So I told you, we know the mode of transmission, how it is getting entering to the our meninges. And now see what is happening there. So you must be heard about bacterial toxins. Yeah, toxins are the virulence characters of this bacteria that will help them to escape from our immune mechanism. So these toxins and inflammatory mediators can cause suppurative inflammations. That inflammation leads to the infiltration and alter the vascular permeability. That leads to the tissue edema. Then it can destroy the blood-brain barrier, lead to thrombosis. So there it reached. So the bacteria reach very easily. And the diffuse bacterial infection mainly involves the leptomeninges, arachnoid membrane, superficial cortical structures, and even brain parenchyma is also inflamed. So this is how a meningitis is happening in man. Coming to the manifestations or symptoms or clinical features. That is, that already we explained in our clinical history itself. So we'll let us discuss in detail some more. Sudden high fever. That is the first thing which we noted. Especially in children, we usually will note like that. Severe persistent headache. That is another thing. Next, the very important thing, that is neck stiffness and pain that make it difficult to touch your chin to your chest due to the swelling around the meninges. Next is nausea and vomiting, or sometimes we can say that is diarrhea also. Confusion or altered sensorium or can lead to the death, drowsiness or sluggishness, even eye pain or sensitivity to bright light, muscle or joint pain or weakness. So main symptoms, another next symptoms, the very important one, Kerning sign. That is Volmer Kerning, 1840 to 1970. That is, he's a Russian neurologist. So in his name, he was the first man who reported this. So it was known as Kerning sign. Is positive. What happened? What is Kerning sign? When the thigh is flexed, you can see in this picture, at the hip and knee at 90-degree angles, and subsequent extension in the knee is painful. That will lead to the resistance. So it indicates subarachnoid hemorrhage or even meningitis. That is one of the most important clinical symptom. Next is Brudzinski sign. Joseph Brudzinski, that is another Polish pediatrician. He is the first person who reported this sign. That's why it is known as Brzezinski's sign. That also will positive. What is happening? Neck rigidity. That is a first, that is a clue I told you in the clinical case history that I told you. Neck rigidity, you should remember. Severe neck stiffness causes a patient hips and knee to flex when the neck is flexed. So that is also here in this child is positive. That is severe neck stiffness. That will lead to the patient. That is when the patient's hips and knee to flex. What happened? That means the neck is flexed. So that will happen in blood mixing signs. Next is another glass test. That is usually we do in case of meningococcemia. That is Neisseria meningitis. That is Waterhouse-Friderichsen syndrome. That is a complication of meningococcemia. That is here the patient appears with these type of rashes. So what usually we'll do the glass test, that is press the side of the glass tumbler against this rash. You can see in that picture. Suppose if the rash does not disappear, suppose after when we are pressing the tumbler in the rash, if the rash does not disappear, then it is a symptom of meningitis. That was also another symptom or the manifestation you can point out to the your probable diagnosis. So this is how the Waterhouse-Friderichsen syndrome of meningococcemia, which is happening due to Neisseria meningitis. Okay. So coming to the etiological, some little bit about the etiological agent. I'm not going in details, not going to, because it is a very vast topic. It will not be covered in this 1 hour. You must be very bored in that. So I put some short, that is a little bit information regarding the etiological agents related to meningitis. Neisseria meningitis, there are about 13 strains, that is different serotypes are there. The mainly A, B, C, Y, W135. They are the most common cause of Neisseria meningitis. And it is second to the Streptococcus pneumoniae. So you must be knowing which must be the first one. The most predominant is Streptococcus pneumoniae. The second is Neisseria meningitis. And that is also community acquired meningitis. That is another important aspect that you will be getting in your community medicine class also. Hemophilus influenza serotype. Next is Hib. That is Hemophilus influenza serotype B. That is B. Hib. Usually we say this Hib. That is the main cause of invasive condition like meningitis and pneumonia in children. So there also comes the meningitis. Next is Listeria monocytogenes. That is the third most common pathogen causing bacterial meningitis in adults. It is most commonly coming to the adults, not in like neonates or children. It is comparatively less, but it is mostly in adults. Okay. Next, very important topic, that is laboratory diagnosis. It can be, you can get a 5-mark question of laboratory diagnosis of meningitis, not only in microbiology paper, even in your clinical medicine paper also you will be getting, infectious medicine also you will be getting, even in pediatrics also you can get a laboratory diagnosis or what is the diagnostic steps you should take in a case of meningitis. So whenever you are dealing with a laboratory diagnosis, you should first give importance. When you're writing about laboratory diagnosis, first you should write about the specimens or the clinical material which we are collected in that particular condition. Is it? So which are the specimens we can collect in days of here meningitis? CSF obviously. Even blood culture also can be done, and even nasopharyngeal samples can also be collected. So among this, which is the most important and most that is precaution needed one to collect sample, that is CSF only. So CSF collection, that is also another important question, how CSF is collected. So that is by lumbar puncture. Is it? And it is only done by a trained physician, and they can collect. That is, it can collect only 3 to 5 ml into a labeled sterile container for the microbiological investigation. That is the very important aspect. It should be a labeled sterile container. And removal of large volume of CSF can lead to headache, and it should be that fluid should be collected at the rate of 4 to 5 drops per second. Okay, if sudden removal of fluid is allowed, that is, it can draw down the cerebellum into the foramen magnum and compress the medulla of the brain. So that is why a very trained person that has to be done, not done by other people. Coming to the analysis, how we will done. a spinal tap or otherwise known as lumbar puncture is performed. So where it is inserted a thin needle that is inserted between L4 and L5 to withdraw the sample. The sample is sent to laboratory for investigation. Usually, 3 tubes of CSF has to be collected. So when you are collecting itself, it has to be separated, collected in 3 tubes. So what is the use of 3 tubes? One is for the chemistry analysis, that is for the biochemical investigations, glucose, protein levels, and even cell counts, and other for the microbiological analysis, and other one for the cytological analysis. So that is, you should remember, when you're collecting the sample of CSF, collect in 3 bottles, separated in 3 bottles for biochemistry, microbiology, and even cytological analysis. So that investigation, these 3 investigations together will help you to find out or to get a probable diagnosis. Okay, so suppose after collection, if you are, that is, if any delay is anticipated, you should not refrigerate the CSF sample. Usually, CSF samples you should collect, it should be transported very fast to the lab. Otherwise, if any delay, keep in the room temperature. Why? Because Hemophilus influenza, that is one exception. Usually, one of the most common cause of meningitis can, that is, it can be killed when it is refrigerated. So, do not refrigerate CSF sample if you have any delay, or if you have no other option, because it should be getting delayed or no one is there to take the sample to the laboratory, so it should be taking some time. Should, the ideal thing is you should leave it in room temperature. That is the first, another important thing you should remember. Because suppose if you refrigerate it and send to the laboratory, and the patient is having an Haemophilus influenza condition, when we culture the sample or when we see the microscopy, the investigation, the report comes as negative. And what will be the diagnosis? And can be, you can miss the diagnosis. Okay, so that is why we told you that it should not be refrigerated. Okay, next, come to the next, that is after sample collection, the samples has to be analyzed, CSF sent, and next our first procedure is microscopy. So the CSF sent to the laboratory, we done the microscopy. That is the first and foremost staining method. In microbiology, you all know that is gram staining. Then gram staining, you can see, I put the pictures, you can see here. That is Neisseria meningitidis. You can see it's a gram-negative diplococci with adjacent side flattened. And then and the next one is Haemophilus influenza. It is a gram-negative coccobacilli. Listeria monocytogenes, gram-positive bacilli. And Streptococcus pneumoniae, it is a gram-positive diplococci with lanceolate or flame-shaped. So that you all know. That is, this is how the morphology we can see if it is there in the, if any organ, like these organisms seen in the CSF. So the gram staining, it need a very good experience. The experienced person only we can, because presence of one bacteria itself shows the CSF is infected. Understood? So the very, that is, it is more chances that we can miss even that one bacteria in the CSF. It will not be seen like plenty of bacteria. Usually CSF hardly we are getting in, that is when we examine 50 or 100 field, we can sometimes we can see 1 or 2 bacteria. So it will not be missed out. So that is one problem of gram staining. So compared to gram staining, fluorochrome stains or fluorescent stains are now very common. So there, bacteria can appear bright red. So it is very easy. We can, that is more sensitive than gram stain. So nowadays, fluorochrome stains are also being used. So it is very sensitive. We can very rapidly find out or differentiate the bacteria which appear very bright red. Next comes to the major or the backbone of microbiology, that is the culture. So in culture characters, first one we will see what happens in Neisseria meningitidis. That is, as you know, that is these 4 organisms. They are not like common organism. They need enrichments, special nutrients or special atmosphere need to be there for its growth. So the first one, Neisseria meningitidis, The media which we are usually commonly using is chocolate agar, blood agar, New York City medium, thiamartin medium with carbon dioxide. And we can see catalase and oxidase tests were positive for this. So I put in the slides only the major differential characters or the major media with the differential characters. Not included the vast or the major things, but the minimum, that is at least you should write these much points. It is very important. So Haemophilus influenza, we can see blood agar, even chocolate agar, Fields agar, Lewinthol's agar, and in blood agar, in Haemophilus, one more peculiarity is there. It requires factor X and factor V for its growth with carbon dioxide, and it can show satellitism also. So these next comes to the Listeria monocytogenes. Here, Muller hinted agar with sheep blood or blood agar with a small source of clear beta hemolysis we can be seen, and they very well grow at refrigeration temperature, that is 4 to 10 degrees. That is refrigerated food also can be source of infection. Okay, so that is why we are using the cold enrichment method to differentiate Listeria monocytogenes. Next comes Streptococcus pneumoniae. That also blood agar. That is, I put short forms of blood agar and chocolate agar. Don't mistake that. Blood agar. That it shows alpha hemolytic with draftsman colonies. What do you mean by draftsman? Otherwise, you can say carom coin. You must be heard about the carom coin which you are playing. So that carom round like appearance will be there. It is optochin sensitive, bile solubility is positive, and inulin fermentative. So these are the major cultural and biochemical identification to differentiate meningitis, influenza, monocytogenes, and even Streptococcus pneumoniae. So that is about the culture or identification. Next comes to the now how the CSF examination comes. So the normal microscopy of the CSF we done by gram stain. Before that, we will get the idea that that is the bacteria. The patient is having a bacterial meningitis. How will you conclude from the CSF reports? So the normal CSF, which is a clear colorless liquid, like our water, okay, and it is having 0 to 5% of 0 to 5 lymphocytes. It is sterile. That means it is not at all uh, presenting and having any microorganism. It is completely sterile in normal case. 150 to 450 milligram per liter of protein and 2.8 to 3.9 millimolar per liter of glucose. So that is actually how the normal CSF appears. So what happened in this slide? What you are seeing, is it clear? This is a bacterial meningitis CSF. So here it is, sometimes we can say it is not clear. What it is says, it is turbid. And what about the cells? 500 to 20,000 or even more, mainly the polymorphs, and very few lymphocytes you will be seeing. And bacteria in the gram stain. We can see bacteria in the gram stain, markedly raised or elevated protein or reduced level of glucose. Why the protein is elevated? Because the bacteria start make utilizing and the sugar and protein metabolism started. And what happens, this shows the presence, that is we can suspect, yes, this condition can be a bacterial meningitis condition. So now in this slide I'm not going to the viral or tuberculous meningitis, I'm not going, but now at least you should give importance. Now you must be very clear about how will you differentiate from a bacterial meningitis condition. Okay, we'll go to the next slide. That is Quellung reaction or capsule reaction, or for the detection of capsule in the bacteria. So it is actually another that also you studied, maybe most of you maybe studied Streptococcus pneumonia, Neisseria meningitis, or even Haemophilus influenza. All three are capsulated organisms. So capsule, that is a another virulence character of this bacteria. So when we put the anti-zera of specific for the capsular polysaccharides and mixed with this bacteria, what happened? We can see an antigen antibody complex formation in the bacteria, and it enhance the refractive indices of this capsule, and the capsule can be seen as clear and swollen around the bacteria. So this is how the normal bacteria in the stain we can see. But when we mix this bacteria with the antisera of their capsular polysaccharide, this capsule will become clear and swollen. That is detected by Quellung. So that's why it's a Quellung reaction. This can also be asked for a 2-mark short note question. What is Quellung reaction or capsular reaction? So this is another identification character to differentiate is it pneumonia or meningitis or Haemophilus influenza. So another other methods. So these are the primary methods you usually go for. Next comes to the methods for detecting bacterial antigens. That is another very important rapid polysaccharide antigen detection. That also very important and very rapid thing which we are usually using. Rapid polysaccharide antigen detection and counter immunoelectrophoresis, co-agglutination test, lactase agglutination test also very useful. That is CSF lactate is raised in bacterial meningitis. That is another biochemical condition which is lactate the CS will be raised. That is a very important clue for bacterial meningitis. Then other methods, even PCR also is very commonly we are using for the, because meningitis is a medical emergency condition. You should have a proper diagnosis and should save the patient with appropriate treatment with the appropriate time. That is, the time is very important because you will not be getting more time because it's an emergency. The patient can collapse very fast when a meningitis condition is going on. So, along with all these investigation, obviously the first one we will start is because I put in the last portion, but in case because when we are regarding microbiology, the other methods we are putting in the last this thing. So, along with this bacteriological CSF, lumbar puncture, and all these things, CT or even MRI has to be done. They will do that first, preferably the first choice, and even uh, CT, that is MRI, is preferred over CT due to its superiority in demonstrating areas of cerebral edema, ischemia, and meningeal inflammation. So that is related to the other radiological investigations. We'll go. Next comes to the treatment and prevention. So I told you it's a medical emergency. It is important to start the treatment as soon as it is diagnosed or even suspected. Diagnosed means that is the patient come to the emergency. You got the manifestations of this the child with high fever, neck rigidity, burning signs positive, Bretzinski signs positive. You should start the treatment first. Then only go for the CT or even lumbar puncture next, because that I told you meningitis very that is depends upon the age, very short incubation, it can be fatal. Okay, suppose we'll see. Suppose we got the and started with the treatment. After that, you can go for the at the same time you can collect the sample for the investigations and go for the CT. And after getting the report, you can change or escalate or de-escalate the drugs. Okay, Streptococcus pneumoniae. So the right choice is penicillin. That is, here I am telling you only about the drug of choice, penicillin G or ampicillin or even vancomycin plus third generation cephalosporin. That is the usual drug which we are using for that can cross the blood-brain barrier. That is ceftriaxone or taxim, cefotaxime. Okay, so third generation cephalosporin. Even Neisseria meningitis is also penicillin G or third generation cephalosporin, taximor zone. And Haemophilus influenza, third generation cephalosporin, listeria, that is cephalosporin is not using, and ampicillin or penicillin G, that is choice, E. coli, third generation cephalosporins, group B streptococci, also you can use penicillin G. So this is the drug of choice, and usually resistance pattern is comparative to other bacteria or other conditions, it is a little bit low, but resistance are reporting. Okay. Along with the treatment, there is another important factor you should remember in case of bacterial meningitis, that is chemoprophylaxis. That is prophylactic treatment of family members, even medical persons or children, those who are close contact with the patient. That is also very important thing. Here, rifampicin usually will give to family members for infected person to reduce their risk of contacting the disease. But it should not be given in pregnancy. Pregnancy, it will not, rifampicin should not be given, can be given with the ceftriaxone, one dose of azithromycin or ciprofloxacin can be given. So that is also very important part along with the treatment, this prophylactic measures, because I told you close contact or droplet infection can is very easily, these conditions can be spread, that is meningitis can, bacterial meningitis can be spread from one person to person. So close contact of family members, medical persons, or those who are having close contact with this patient has to be taken the prophylactic medicine along with the treatment of the patient. Next, another important 5-mark question or a 2-mark question, you can say. What is the immunization or prophylaxis or prevention? So, then this first slide of case history, hope you remember that I told you the patient is having a current immunization status because all the immunized vaccines are up to date. But what happened? Okay, so among the immunization, I am talking about in our country, that is our immunization schedule, usually the national immunization schedule in India, we don't have any meningococcal vaccine, it is included. That's an optional vaccines. Meningococcal vaccines are not included in our national schedule. Okay, so meningococcal vaccines are optional vaccines. Okay, there are two types of meningococcal vaccine. Now, the one more there, three types are there. One is polyvalent vaccine containing serogroups A, Z, Y, and W135. That is effective in people older than 2 years of age for prophylaxis, along with that is adjunct to the chemoprophylaxis. The vaccines are purified, heat stable, lyophilized capsular polysaccharides. Next is meningococcal conjugate vaccine. The first one is a polyvalent vaccine. It is a next is a conjugate vaccine that is recommended for children of 11 to 18 years who have been having been vaccinated in the early life and who are high risk of people, that is who are because of having close contact, especially the laboratory workers, healthcare persons, or overseas travelers, they can be taken. And that is one dose actually given. But here you can see the serotypes A, C, Y, and W135 included, but B was not included in the previous two vaccines. So nowadays, that is recently, serogroup B meningococcal vaccine also available, that is available in USA, not in India. So these are the meningococcal vaccine, that is B meningococcal, serogroup B meningococcal vaccine, and polyvalent or meningococcal conjugate vaccine. Next is Haemophilus type B. So that you must be heard. In our national immunization schedule, we are giving this HIP vaccine to our children. This is a part of recommended schedule. 3 doses given at 2, 4, 6 months of age. A booster dose is given 12 to 15 months of age. Next is pneumococcal conjugate vaccine that is recommended for children under 2 to 5 years and who are at high risk, that is weak immune system. Those who are having weak immunity, they are recommended with this vaccine. That also 4 doses has to be given, 2, 4, 6 and 12 to 15 months of age. Next is pneumococcal polysaccharide vaccine. That is for adults, that is more than 65 and children of more than 2 years who have long-term health problem, that is weakened immune problems, those who are having, they have to be taken with polysaccharide. That means adult patients has to be, here also this vaccine is available, optional vaccine, pneumococcal vaccine here in India also. It is recommended for adults, that is more than 65. Why? Because adults, that is when you studied streptococcus pneumonia, those who studied, you must remember, hope you remember that its other terminology is old man friend. Streptococcus pneumonia is otherwise known as old man friend. Why it is old man friend? Because this pneumonia, streptococcus pneumonia can cause pneumonia in elder patients. That is why we are recommended for this type of vaccine for adults more than 65 years and those who are not taking the early childhood vaccines also more than 2 years. So that is about the prevention or prophylaxis. Now you have what you should remember, what you should take home. Today in this session we deal with the bacterial meningitis. What are the etiological agents of bacterial meningitis? Hope you remember. that can be asked for a 2-mark question. Sometimes they can allow, that is at the same time they can put a question of morphology of Neisseria meningitis. That is, what is the morphology of Haemophilus influenza, Streptococcus pneumoniae. They can be asked in viva, also can be asked. Next question, pathogenicity and clinical features. That also I explained. What is, how the meningitis is transmitting, what is happening, how it reaches the brain, and what it happens, the events which is happening up to in the brain. Next comes to the laboratory diagnosis. Another important question. You should be, that is not in the examination point of view. In the that is laboratory diagnosis, you should know when you have a emergency patient like this, what are the diagnostic tests have to be done to confirm my diagnosis. So laboratory diagnosis, what are the specimens, when I have to collect, what are the tests I have to be opted for the investigation. You should know laboratory diagnosis, treatment, and the prophylaxis. Prophylaxis also another very important aspect. So these are the main questions. What are the etiological agents, pathogenicity, its clinical features, laboratory diagnosis, treatment, and prophylaxis. Main questions you can come across in your examination of a 5-mark question, of a 2-mark question, or even a clinical essay of 10-mark question. Okay. So from this, I think you must be stuffed with meningitis. Your meninges is stuffed with meningitis. Now we will have a refreshing. So we'll start some questions like a MCQ, like usually. So it will be easy. I put the options also, so you can opt. So the meningococcal infections are predominant in which of the following age groups? So which of the following age groups it can be predominant? Can anyone tell? That is, I already put in the slide. It is explained. So which are the main group which is mainly, that is, we can see with the most predominant groups. Is it infants, children, or young adults, or adults, or children and adults? So the answer is children and adults. So both children and adults can be get the infection. So which of the following is true about CSF analysis in bacterial meningitis? So what can be the CSF appearance? What will get, what assessment you can get from this in case of bacterial meningitis? Is it a raised CSF lactate suggest a tuberculous disease? Antibiotic therapy should be delayed until after a lumbar puncture to ensure that bacterial cultures are positive. Common bacterial pathogens may be identified by rapid polysaccharide antigen detection. Which is the correct answer? The correct answer goes, common bacterial pathogens may be identified by rapid polysaccharide antigen detection test. The next question, among the serogroups of Neisseria meningitis given, which are the most important associated with meningococcal infection? Which are the main serotypes which we explained in case of meningitis? A, B, C, Y, and W135. So which is administered, next question, which is administered as prophylaxis to close contacts of meningitis? Which is administered, is it penicillin, ceftriaxone, or taxim, or rifampicin? So the option is rifampicin, that is actually used for the prophylaxis of close contacts with meningitis. Hope you got clear. Okay, next, older adults are more sensitive or susceptible. Older adults are more susceptible to pneumococcal disease, including meningitis and pneumonia. Is it? So, is it true or not? Is it true or false? That is true. So, how come it's true? That is, older adults, what happened? Older adults are more susceptible to pneumococcal disease like meningitis and pneumonia. Next, which of the following is an abnormal cerebrospinal fluid finding? That is, a glucose level that is less than 50% of the plasma glucose level is actually the abnormal finding of CSF. So that is all about, I think we finished with the bacterial meningitis. And I think if you have any query, you can ask in the comment box, you can, or otherwise you can type the queries. Hope you understood a little bit. At least you should know what are the conditions, or what is meningitis, what it transmitted, what is its pathogenicity, how it appears, how can we diagnose, what is the treatment, and what are the preventive measures we can take for the bacterial meningitis.
Thank you so much, ma'am. It was a very detailed and wonderful session, as well as the clinical aspects and also the theoretical aspect for the students and as well as the viewers. I hope all the viewers and the subscribers would have got benefited through the session. Let's wait for a few minutes for the queries from the viewers, ma'am. So meanwhile, ma'am, can you please stop sharing the slides, please? Ma'am, you're there? Okay. Thank you, ma'am.
Thank you. Thank you.
And we'll just wait for another few minutes for the comments from the audience in case of any queries or clarification.
Okay, okay.
So, students and viewers, I hope you have all enjoyed the session, and please share our YouTube channel and the Facebook page, and the link has been given. You can also access the recorded video, MCQs, and announcement of all the sessions at our Facebook page. So, in tomorrow's session, we have the topic myocardial infarction from 5 to 6 p.m. by Dr. Asithu Debroy from MGM Medical College. And the second session is on the topic A to Z of ECG. The part 2 of the session has been taken by Dr. Vinod Doraisamy at 6:30 to 7:30 p.m. And thank you so much, audience, for listening patiently. And ma'am, since there is no queries or any clarification, we can just wind up the session. We have the topic myocardial infarction from 5 to 6 p.m. by Dr. Asithu Debroy from MGM Medical College. And the second session is on